When I'm seeing a patient for an evaluation of axial spondyloarthritis, I'm first going to conduct a really thorough history. When did the pain start or the stiffness start? What were the symptoms that they've experienced? Have they had peripheral symptoms? Is there stiffness in the morning when they first wake up? What makes the pain better or worse? Does physical activity, for example, make the pain better, or does that make it worse? These are the kinds of things that are going to help us understand whether there's inflammatory back pain or mechanical back pain. So if you're getting more pain with physical activity, that's going to lead you more to the mechanical side as opposed to the inflammatory side. NSAIDs can help both, so NSAIDs aren't that good of a separator, but sometimes they help you understand whether or not there's an inflammatory component there too. After I've done the history, I'll go on to do a physical exam. And the main point of the physical exam is really locating where is the pain. A lot of times when patients are presenting with back pain, it's actually in the musculature. And then that helps you because that's unlikely to be axial spondyloarthritis. It's going to be more mechanical. If it's over the spine or particularly within the sacroiliac joints, then we're going to be thinking more about axial spondyloarthritis. Additionally, if there's both components, then you know that physical therapy is definitely going to be necessary to help kind of sort out what components of the back pain are related to the axial spondyloarthritis compared to more mechanical back pain. Next, we're going to get some laboratory values to help us. The most helpful labs are an HLA-B27, given that you have the pretest probability that this patient may have axial spondyloarthritis, and a C-reactive protein, because if it's elevated, it's helpful. If it's not elevated, it's actually not that helpful. About half of our patients don't have an elevated CRP. ESR is not really used in axial spondyloarthritis anymore, just because it's not as specific. And then we're going to get some imaging. So we're going to really focus on the sacroiliac joints. We're going to get an x-ray of the SI joints first. And again, you want to order it for the SI joints so that they angle the joints right, because otherwise if you just get an AP pelvis, you're not going to get a good view of those sacroiliac joints. And then after we get the x-ray, let's say the x-ray is completely normal, then we may go on to get an MRI of the pelvis to assess for inflammation. And that's going to be ordered slightly differently depending on where you are. I order an MRI of the sacrum. We never need contrast, we need fat-suppressed images. So MRI without contrast of the sacrum, and then you write in there that you're evaluating for sacroiliitis or ankylosing spondylitis, and then they should get the fat-suppressed images. So when I think about the importance of treatment initiation, it's going to differ based on whether or not the patient has active inflammation or not on the MRI, and whether or not they have radiographic damage. If they have radiographic damage, especially if they have HLA-B27 also positive, a C-reactive protein is elevated, and they are man, that patient is much more likely to progress. So we want that patient on therapy sooner than later. So an NSAID is a good place to start for symptom management, but the TNF inhibitor or an IL-17 inhibitor, for example, is going to prevent longer-term damage. So we'd like to get them on a biologic. On the other hand, the patient with non-radiographic disease, we want to control their symptoms, but there's a little bit more wiggle room in terms of the timing of starting therapy. So you may be able to watch them on an NSAID alone, for example, over the period of a year to see if there's any change. We know that about 16% of these patients will go on to develop radiographic damage, and many of those already had something on the x-ray to point to the fact that they were developing damage. So that group, you just have a little bit more time to get them on a biologic if that's the appropriate next step, and it may not be. Radiographic damage, elevated C-reactive protein, HLA-B27 is positive, or a man, those are the patients we want to get started on therapy earlier rather than later.